It's Friday, the 7th of November, and this is the Hot Topics podcast. Welcome to the Hot Topics podcast from MB Medical. It's Neal Tucker here as ever to have a chat about what's been going on in the medical literature relevant to us in general practice over the last month. The clocks have changed. The evenings are growing dark fast. Practices in England are being told that diverting patients to 111 when you've reached capacity isn't lawful in the contract changes. And we may be heading for industrial action again. But at least no one's given me any spoilers for the Celebrity Traitors final yet, which I can't watch until tonight. To banish away those winter blues, we've got 3 great papers today and a fantastic interview relating to the final one. So we're kicking off with a paper on the physiological side effects of antidepressants and how they rank against each other. Then we're going to have a think about which exercises are best for osteoarthritis-driven knee pain. And then finally, we're going to have a look at a paper on PSA testing intervals and trends in general practice. And then have a chat with some experts about the variation in testing, particularly in relation to black men and their increased risk of prostate cancer. Now, as the general news is generally depressing, we'll have some positive news with what's going on with MB Medical. So we've got our new urgent care course coming out on Saturday, the 5th of November. Totally updated from last year. Myself and the fantastic Rachel Brattel will be presenting that one. Join us for the live webinar. Busy time of year actually for NB, so we've just done the live webinar of our cardiology and ECG course today. If you didn't manage to catch it live, catch it on catch up. Too many catches? Not sure. We've got our abnormal blood results course tomorrow, palliative care and end of life course coming up next Friday, then men's health, cancer, diabetes, plus the new Hot Topics course, all coming up before the end of November. Check out the mbmedical.com website for details. Don't forget, if you join MB Plus, just over £300 a year, you can come on all of those courses for no extra cash and you get a range of other perks too. Okay. On to the research, and let's start with our first paper. This one hit the headlines a couple of weeks ago. You will have seen this in the news, heard it on the radio, I'm sure. The effects of antidepressants on cardiometabolic and other physiological parameters, a systematic review and network meta-analysis. The opening line of the paper's introduction sets the scene. 17% of the adult population in Europe and Northern America are prescribed antidepressants. It is a staggering figure. I always take these with a little pinch of salt. It's like going shopping for Black Friday where everything is up to 50% off and you find that actually only it's the horrendous multicolored shirt that looks like it's been vomited on at the back which has been discounted. But you and I are the ones prescribing loads of antidepressants every single day, so perhaps that figure isn't so far off the mark. This is the same research group, well, at least it's the same lead author, Professor Andre Cipriani, who published a seminal paper in 2008 showing that all antidepressants are more effective than placebo, although often not by as much as we might hope, as there's often a big placebo response. Now this group turns its attention to the potential side effects of these drugs. We all know about and counsel our patients about side effects of antidepressants, so particularly in the first week or so of taking them, the enduring sexual side effects, the potential for mood to deteriorate rather than to improve. But have you ever thought about the effects on your patient's weight, blood pressure, glucose levels, cholesterol, liver function? No, me either. Well, perhaps we should. So the researchers included randomized controlled trials comparing antidepressants and placebos for acute monotherapy of any psychiatric disorder. 151 studies met the inclusion criteria. That included 58,000 patients examining 30 different antidepressants. Who knew there were that many antidepressants? They looked past the usual results on efficacy and looked at the documented physiological observations in these paper comparing changes over the first 8 weeks of use against placebo, and then, as part of the network meta-analysis, comparing them against each other as well. The results, to quote the paper, showed frequent and heterogeneous physiological side effects across different antidepressants. The magnitude of some physiological alterations, in particular change in weight, heart rate, and blood pressure, is large and clinically relevant. Okay, so there's a lot to unpick here. This made the headlines of the mainstream news, so our patients will be aware of this. Some of the specific headlines: weight gain of up to 2 kilos, changes in heart rate, blood pressure difference of 11 millimeters of mercury on average. These all sound pretty significant, but before we start getting really worried, we've got to go into a little bit more detail. When you look at antidepressants, it's clear that different ones have different effects on physiology, but the good news is that the big changes, the headline grabbers, are almost all associated with antidepressants that you and I are unlikely to be prescribing. For example, agomelatine was linked with a 2 kilogram average drop in weight versus placebo, whilst maproteline was linked with a 2 kilo weight gain. The former, I can't think of any of my patients who are taking it, and the latter, I've never even heard before. That's why I can't pronounce it very well. More importantly, however, amitriptyline was next on the list for weight gain, although things do start getting a bit messy here, as the researchers also report that 46% of users of amitriptyline showed 2 or more kilo weight gain, but 20% lost 2 or more kilos. There is no one size fits all here. The paper also can't tell us what dose of amitriptyline induced those effects. So is prescribing 10 milligrams as bad as prescribing 150? We just don't know. Perhaps most usefully, commonly prescribed medications such as escitalopram, citalopram, fluoxetine, sertraline were neutral or led to slight weight loss on average compared to placebo. And this is a pattern that also follows most of the time with cholesterol, glucose, and blood pressure. That last one, blood pressure, perhaps the one to flag is venlafaxine. That was associated with an average net gain, possibly fluoxetine too. Mirtazapine, not so good for the weight. Duloxetine, not so good for liver markers. Perhaps the key limitation of the study, that these results only report on changes over the first 8 weeks of use, is also perhaps the biggest concern with these results, the fact that these changes happen so quickly. The paper gives an example of amitriptyline, which in just 8 weeks can drive weight gain of 1.5 kilos, increase the heart rate by 9 beats per minute, and the systolic blood pressure by 5 millimeters of mercury. This has substantial implications for long-term cardiovascular health and mortality. What the hell is happening to our patients using it for months or for years? We simply don't know. The flip side of this data, the caveats being the limited timescales that it has been examined over, but the flip side is that the commonest medications we prescribe are overall fairly neutral in their physiological effects. The authors, when interviewed, suggested that this data would break the monopoly on the highest prescribed generic medications in the UK. So citalopram, sertraline, fluoxetine, they come out top, accounting for something like 85% of all antidepressant prescriptions. And that it would encourage more patient-specific prescribing using the growing range of alternative options that we've got. But I think they might have misunderstood what general practice finds useful. In my mind, as prescribing in all areas of general practice gets progressively more nuanced and more complicated, I think this study might actually drive antidepressant prescribing further the other way so that we use less medications generally. If you and I know that these 3 treatments are overall the safest, then I'm inclined to forget the rest. Skip mirtazapine because it can cause weight gain unless people really need a good night's sleep. Forget venlafaxine in older people because it can put up your blood pressure. The other 24 on the list that we've pretty much never heard of, Forget them, who cares? I've got hundreds of other medications for hundreds of other conditions to remember. I'd like to make our lives as simple as possible as long as it's not negatively affecting our patient. In conclusion for the study, it shows that antidepressants differ markedly in their physiological effects, particularly on cardiometabolic parameters. Good news for us, the most common ones that we prescribed tends to be the ones that have the least effect. Okay, on to our second paper. This was published in the BMJ 2 weeks ago, and I think it must have caught my eye because I'm sure, like many of you, I've had problems with my knees over the years. I can't remember if I bored you on the podcast about this before. I certainly bored other people. I was at a birthday party a couple of weeks ago and someone was asking me if I've done any interesting cycling trips recently. And after about 5 minutes, I'd realised I'd just been boring them to death about my hurty knee. I've become that person in middle age. Sorry, Johanna and Mike, I will try harder next party. Anyway, this paper is all about the best way to help knee osteoarthritis through exercise. It's another systematic review and network meta-analysis. There seems to be a theme on the podcast today, looking to assess the safety and efficacy of a variety of different exercise modalities for managing knee osteoarthritis and pain. The reason this is important is because the guidelines currently don't provide much information about the specific types of exercise intervention that we could be advising to our patients and may well be the best. And of course, exercise means a lot of different things to a lot of different people. Plus, I don't know if you're the same as me, I just find myself referring to physios a lot. They're overwhelmed. It would be much better if we could help people help themselves. But is there one method that comes out best overall? Should certain interventions be recommended for certain patients? Or indeed, should they be avoided because they may be dangerous? Now, this has been looked at before with an earlier paper published in 2019, but as the authors point out, the literature search there actually was conducted up to the end of 2017. That's 8 years ago now, and there's been a whole range of randomized controlled trials looking at this topic, and so the paper needs to be updated. Not only that, but they look to give better information through better refinement of the exercise classification and examining different follow-up durations. Apparently, they identified 45,000 potentially relevant studies in their initial search, and after doing a bit of fettling, they managed to get that down to 14,000. They then went and they screened the titles, the abstracts in the full text of those 14,000 articles. There's about a dozen authors on this paper, but that sounds to me like it's almost a lifetime's worth of work. God only knows how they managed to actually get through all of that. Ultimately, 217 studies were included with a total of 15,500 patients. The studies were grouped by the type of exercise that was involved. So that could be aerobic, which would include walking, cycling, swimming, I think running as well. It could be mind-body exercise, such as yoga, Pilates and Tai Chi. Flexibility training, where people are doing stretching and range of motion exercises. It could be neuromotor exercises. I had to look this one up, but it would include things like specific balance exercises and sensory motor training. Apparently that focuses on postural control and progressive challenges to the sensory motor system to restore normal motor function. It might be strengthening exercises, so doing things like core, hip, knee, multi-joint strengthening exercises. Or it could be mixed exercises, where the majority of those would contain some strengthening component and then do something else as well. The authors then scored how effective each of these groups were for a number of different categories, including pain, function, gait performance, and quality of life. And then they looked at the results at 4 weeks, 12 weeks, and 24 weeks, where the studies contained that information. Not all of the studies provided results on all of those different domains all of the time. As you can imagine, there are a lot of results that are generated out of this data. There's the usual spirograph pictures that we see with network meta-analysis. They're not as pretty as the ones in the first study, I have to say. but they're still pretty impressive. There's also the biggest forest plot table that I've ever seen. That forest plot does highlight some of the key limitations of the study. Firstly, when you're looking at so many categories, even with a relatively large number of study participants, some of the groups have really small numbers in. So, for example, the quality of life assessment at 4 weeks for aerobic exercise is based on just 16 patients. Unsurprisingly, the confidence intervals are therefore very wide, and it fails to provide a statistically significant result. Kind of going along with that theme, the certainty of the evidence is at best modest, often low, and occasionally very low. One of the problems with putting low quality studies into a systematic review like this is that it doesn't provide you with huge confidence in the result that's being spewed out at the other end. Anyway, I've got the caveats out the way. What did the results show? Well, to cut a long story short, aerobic exercise came out top overall across the different categories and timescales that were examined. That's not to say that the other exercise modalities were ineffective. All of them may, or probably, these are the scientific terms in the paper, result in a large increase in performance in some of those areas that they looked at. It's just that aerobic exercise had more consistently positive outcomes. All of the methods were as safe as whatever control groups they were compared against. I don't know what they're doing in the control groups, sitting and scrolling on Facebook or TikTok whilst eating crisps. Whether that's safe is perhaps a debate for another day. Depressingly, none of the interventions resulted in a statistically significant improvement in quality of life at any time point. The linked editorial also highlights that none of this tells us about the effects of people beyond 24 weeks, which feels like a definite limitation for a lifelong condition. Where does this all leave us? My YouTube feed currently shows me lots of adverts about absolutely ripped guys extolling the virtues of Tai Chi and saying it's the only exercise I need to get a body like theirs. I think it must be because I was Googling papers on Tai Chi and Parkinson's a few weeks ago. I'm not sure. Anyway, I'm pretty sure that all of these beefcakes are on roids and haven't seen a carb in years. Cream cheese and tuna for lunch is not my idea of happiness. Nevertheless, Tai Chi may be helpful for knee pain, but aerobic exercise trumps all the others, which is great because perhaps just going out for walks is enough for most of our patients. It's something that most people will be able to manage and hopefully maintain. It seems to me, it feels intuitive that if you're wanting to have continuing benefit from this, you're going to need to keep going. Actually, a word on that, because as the paper points out, the data on exactly that, so the requirement for continuing exercise to help with the pain is a little bit sketchy. There's some data that shows you don't need to do that, which absolutely baffles me. Personally, I think it's probably going to be much better if you can find something that patient is A, willing to do, and B, enjoying enough, or maybe not enjoying, maybe just seeing the benefits of enough that they can continue that long term. So given that all of those exercise modalities showed benefit in some area, I think the key here really is finding what is going to engage the patient the best. As a quick aside, the New England Journal of Medicine published a paper in the past week on a randomized controlled trial of physical therapy for meniscal tear, OA, and knee pain, exploring whether adding text messages or physio to home exercises improved outcomes. Neither did. So perhaps many of our patients don't need that referral to physio. They can start off by just going for a walk, doing some online yoga or Tai Chi. Or I found an exercise plan from a guy with a YouTube channel to be actually the only thing that helped my hurty knee problem. In my defense, I came across him when looking for books to help with knee pain rather than on YouTube. But actually, I found it really useful. And it turns out that the series of several exercises that he suggests is the foundation for lots of knee physiotherapy. So I tell a lot of my patients about this. I signpost them towards this book now, and I'll put a link in the podcast description if you're interested in checking it out as well. I got it off of Amazon. Other booksellers who aren't about to destroy the world through AI domination are also available. I'd be interested to know what you make of it. Now, on to our third and final paper, and we're going to talk about prostate cancer, and particularly we're going to think about prostate cancer in black men who, as you will all know, have a dramatically increased risk of the disease compared with other ethnicities and worse outcomes. I'm lucky to be joined today by two experts in this area. So Dr Bunmi Olajide, who is a GP in Romsford and has a specialist interest in cancer, particularly prostate cancer, and Kevin Howell, who is the Black Health Equity Engagement Manager for Prostate Cancer UK. And a big thank you to Prostate Cancer UK, who have sponsored this interview. I'm actually going to start with this very recent paper. You may have seen this one. It has been in the news as well. It's been a busy few weeks with research since the last podcast. This was published in the BMJ 4 weeks ago. Prostate-specific antigen retesting intervals and trends in England, a population-based cohort study. The authors collected data on male adults from various sources, including GP and national database systems, between the years of 2000 and 2018. 10 million patients were included, and they wanted to look at use of PSA testing in English primary care, including how often people were being tested, being retested, who was being tested, and how this all changed over time. Around 1.5 million men had a PSA test from that study population during this period, with more tests being done in recent times than when it started at 2000. At least half of those patients had one or more further tests. Testing rates varied with region, ethnicity, deprivation, family history, and more. And the authors highlight the marked variation in rates of testing generally. So just to highlight that variation, if you live in the northeast, you were around 40% less likely to have a PSA test than if you lived in the southeast. If you lived in the most deprived areas, you were 25% less likely to have a PSA test than those in the least deprived areas. And if you're a black male, while you are more likely to be tested than a white male, the difference is quite small. And when you think about the fact that they have a significantly increased risk, double the risk at 1 in 4 black men developing prostate cancer in their lifetime, that small difference perhaps doesn't feel like it reflects that overall risk. I think this might be a good point to bring in our guests. Let's do some introductions first. So, Bunmi, could you introduce yourself to the listeners, please?
Yeah, thanks, Neil. And thanks for the initial introduction. Yes, my name's Bunmi. I'm a GP in Romford, interested in cancer, particularly prostate cancer. A lot of my work is around raising awareness and education and actually advocacy with regards to prostate cancer, particularly in black men.
And then let's go over to Kevin. So, Kevin, can you just give our listeners a quick introduction about yourself?
Sure. My name's Kevin Howell. I'm the Black Health Equity Manager here at Prostate Cancer UK. And my role is to raise the awareness of prostate cancer, the heightened risk of prostate cancer in black men within the black community.
Thank you for joining me, gentlemen. So why does Prostate Cancer UK feel the need to have a specific Black Health Equities engagement team?
Because 1 in 8 white men will get prostate cancer in their lifetime, and 1 in 4 black men will get prostate cancer in their lifetime. So because of the heightened risk around prostate cancer in black men, the organisation really wanted to set up a team that can allow it to have an equitable approach to reaching that community.
So could you just tell us a bit about the awareness work that you've been doing as part of your role in Prostate Cancer UK then?
Sure. So I would say we've probably done about 50 events this year so far, and this is up and down the country. And so where we will go into the community and we'll do community events, we will raise awareness, do talks, presentations, as well as partaking in larger events.
And what kind of larger events have you been targeting then?
We attended the MOBOs Awards, also Notting Hill Carnival. There was a big cultural event in Trafalgar Square called Black on the Square. We've even attended one of the largest black cycling events in London called the Black Unity Bike Ride. So there's a number of events that we've covered over the course of the year.
Kevin, when you're doing these groups in the community, you're doing these groups with our patients, what's the kind of feedback you get in terms of their experience about how they perceive the role of general practice, coming to see us about getting tests, talking to us about prostate cancer, that kind of thing?
There's some really key elements to the conversations that you can really pick out. And one of them is thinking that they're going to be called by the GP. The second one, especially men over 50, thinking that it's part of their general health check. And then you've got the other side where there's apprehension about going to the GP. You've got the apprehension around the DRE. So there are lots of misconceptions that we as a team have to engage in to try and break down that there's no screening, you're not going to be called, you need to take ownership of your own health. People who have said, but I went to my GP, and when I went to my GP, they told me, have you got symptoms? They asked me, have you got symptoms? I said, no. And so they sent me away. And so I told them, I am a black man and I have a higher risk, etc. And even in some cases, I have family history. And they still ask me, do you have symptoms? No. Then you don't need to be here. And so these are the variants in responses that we get.
I mean, that's quite an interesting point about the misunderstanding about particularly like the NHS health check. And I see this in my own patients as well. Obviously, we all know, like working in general practice for years, we all know exactly what the NHS health check is. We know that there's a big focus on cardiovascular disease and not much else. And then I think we kind of assume that people will understand that. I'm sure you're right. There'll be a perception amongst a large amount of those people that it's looking at broader health outcomes for that individual. And of course it's not. And PSA, obviously there is no screening program for prostate cancer in the UK at the moment. The PSA is not a routine check. It is something that people have to actively ask for. And of course, lots of people will not know that and not understand potentially that they can go and ask their GP. I guess as you're sort of highlighting there, even then, when they do go ask their GP, Kevin, then clearly people often find that there's a barrier.
Yeah, and it's not it's not across the board, so it's not all GPs, but when we get those kind of responses, it's quite disheartening because we obviously as an organisation we work really hard and tirelessly with GPs around prostate cancer awareness, and especially the increased risk in black men. So to where they on those occasions where they are turned away, obviously then we're trying to battle twice as hard to encourage them to go back, because now a barrier has been created.
Let's bring Bunmi in at this point. I know obviously you've done some work around the data on this, Bunmi. So what does the data tell us about this issue?
PSA, as it stands, is the only test currently available for prostate cancer detection in primary care. And it seems to be the only test that drives eligibility into secondary care. The data is there to say men are at increased risk. We need to change practice from just expecting them to come to us to move into proactively having those discussions with them. We know particularly we're talking about black men here, but I'm adding even men with a family history and men from deprived areas. Every encounter counts. When we see men, I'd say men at risk, it might be just that one missed opportunity and you won't get to see them again in another 3 years. That's the difference between a stage 1 to 2 to a stage 3 to 4 metastatic prostate cancer. So it's heartbreaking. Kevin's touched on it, and I've heard from patients also who've been turned away just because they didn't have symptoms. Yes, we know there's no national screening program for prostate cancer, but what we've got as GPs is NICE guidance for symptomatic men and the prostate cancer risk management guidance for asymptomatic men. And speaking with colleagues and trainees and doing teachings for doctors over the years, what I've realized is there's a lot of focus on the NICE guidelines. And it's almost a number of GPs are not aware of these guidance for asymptomatic men.
Perhaps, Bunmi, what you're saying there could explain some of the findings in this recent data that show there's a 13-fold variation in rates of PSA testing between the highest and lowest practices around the country, which is a huge difference. That's going to be very different experiences that men are getting when they go to talk to their GP about PSA testing and concerns around prostate cancer. I think maybe trying to reduce that variation would be a really good thing. Coming on to the prostate cancer risk management pathway for assessing asymptomatic men. So the guidance has been around for a while now. It's been updated at various points over the years. It still advises that this is something that we can offer to men aged over 50 who come and ask us about a PSA test, and they can have a PSA test after they've been given the relative pros and cons of that. But what I'd never noticed before in 15 years using these recommendations is that it says it does not apply to men at high risk. In effect, we've got no national guidelines that address men, such as black men, who are at substantial risk from prostate cancer.
Yeah, factoring in that there are men at higher risk, and really the guidance should be different for that. You know how it is, Neil, the usual, use your clinical judgment. So it's your GP and you've seen this man, they've got this increased risk. We had a specialist cohort look into what other recommendations could be made. And that was a push by Prostate Cancer UK. And I know we talked about men at risk and black men should be, you start considering from 45, so not 50. Yes, it's not the standard all-out guideline. It's a recommendation. But as a GP, I think I would look at that because that's really based on current research.
And that younger age, that's because if you're in these higher risk groups, you're more likely to develop prostate cancer at a younger age, so potentially pre-50, and it's more likely to be an aggressive type of cancers. So actually, you're more likely to need treatment for it.
Absolutely, Neil. Black men studies have shown over the years younger presentation, more aggressive cancer, and higher mortality rate.
Coming back to you, Kevin, what do you think makes the biggest difference to men when we get this conversation about prostate cancer and PSA testing right?
The biggest difference you make to that man in front of you is relieving them of the anxiety that they had in building up the confidence to actually come to get tested, you know. And I think that probably goes for a lot of men, but it's when you know you're of the highest risk, men talk in their groups or whatever it is. And so when they have that thought process that my friend or my, cousin or uncle, whatever, went for their test and they got turned away, am I going to get turned away? But I'm still going to make up that courage and go. The best thing that a GP can do is actually accept that this is what they want to do.
I tell you, there's a friend, I got to know him through the PCUK platform. Older man, he told me, so he's mixed race, black, and he said he had to go to his doctors a number of times, just asking for a test. He didn't have symptoms then, but he had a family history of the BRCA gene. But that's another risk factor. Those patients, really, we shouldn't be turning away. Take that opportunity when they come in and ask. Take that opportunity when they come in, and if you feel they're at risk, you ask them about their prostate health. And that could make a huge difference.
I think I'm right in saying that one of the biggest barriers to men coming to talk about their prostate health is fear about a digital rectal exam. Traditionally, this has been bundled together as part of screening with a PSA test, but thoughts have changed on this. We realise now that its discriminatory value for prostate cancer is extraordinarily low. So there's a strong argument to say that we don't need to do a digital rectal exam for screening for prostate cancer. Now, sure, you think there's other things going on. They've got LUTs. You think it might be benign prostatic hypertrophy, whatever, that's fine. There's still a role for a digital rectal exam, but in prostate cancer screening is very limited. And then this was further supported in the summer when the British Association of Urological Surgeons came out and said, we don't feel that there's value in doing digital rectal exams in the community for PSA cancer testing. So this actually seems to be making our lives a little bit easier. I doubt there's a lot of GPs out there that will miss doing an unnecessary rectal exam. This is important in the context of what we're talking about today, because I believe the data shows that concerns around the digital rectal exam disproportionately put off black men coming to see their doctor about their prostate health.
Yeah, 100%. We should be working together as opposed to working against each other in terms of ensuring that the man has the easiest experience and is more encouraged to be tested. We're presenting when we're at a later stage of prostate cancer. And a lot of these are because of barriers that are there, the DRE being one of them. When we're talking about advocating for the PSA test, is to make sure that that's one less barrier that the man has.
Well, thank you both for joining me on the podcast today. It's been great to hear your thoughts on this issue. It's really made me think about that variation in practice around the country and what maybe we can do as practices, as GPs, as primary care clinicians to reduce that gap, particularly in those higher risk groups, and particularly as we've been talking about today in black men. Bunmi, thank you so much for joining us.
Thank you, Neil.
And thank you, Kevin.
Thanks for having me, Neil.
I'll pop some links in the podcast description to some of the research we've been talking about and some useful resources as well. So do check that out if you want to know more. That wraps up the podcast today, everyone. Thanks for listening as ever. Don't forget to check out the mbmedical.com website. Have a look at all those courses coming up. Sign up to MB Plus if you haven't already. Remember, you can always get in contact with us on email. So gphottopics@nbmedical.com. You can find us on Facebook and Twitter and so forth as well. And we'll be back in 4 weeks' time. Have a good few weeks. See you then. Bye-bye.